call this meeting to order. Welcome to meeting number 19 of the House of Commons Standing Committee on Health. Today we meet for 2 hours to hear from witnesses on our study of the emergency situation facing Canadians in light of the COVID-19 pandemic. Before I introduce today's witnesses, a few regular reminders for hybrid meetings. Today's meeting is taking place in a hybrid format pursuant to the House Order of November 25th, 2021. Per the directive of the Board of Internal Economy on March 10, 2022, all those attending the meeting in person must wear a mask except for members who are at their place during proceedings. I know that our witnesses, most if not all, have been here before. So you would know very well some of the standard directives. Please wait until I recognize you by name before speaking. If all of our witnesses are appearing by video conference, click on the microphone icon to activate your mic and mute yourself when you're not speaking. Translation is available at the bottom of your screen. You have the choice of Floor, English, or French. Just a reminder to please refrain from taking screenshots or photos of your screen. All proceedings today will, of course, be made available via the House of Commons website. And to the committee members, in accordance with our routine motion, I am informing you that all witnesses have completed the required connection tests in advance of the meeting. So I would now like to welcome our witnesses from the Public Health Agency of Canada who are with us this afternoon. Dr. Harpreet Kocher, President, Dr. Teresa Tam, Chief Public Health Officer, Dr. Howard New, Deputy Chief Public Health Officer and Interim Vice President, Infectious Disease Programs Branch, Cindy Evans, Vice President, Emergency Management Branch, Stephen Bent, Acting Vice President, COVID-19 Vaccine Rollout Task Force, Jennifer Lutfala, Vice President, Health Security and Regional Operations Branch. Thank you all for your service. Thank you all for your presence. Dr. Co-Chair, I understand that you will be making the opening statement, and if my understanding is correct, Doctor, you have the floor for the next 5 minutes. Welcome to the committee.
Thank you, Mr. Chair, and thank you for inviting Public Health Agency of Canada officials to provide an update on the COVID-19 pandemic. We are pleased to be here. Joining me today are Dr. Teresa Tam, Chief Public Health Officer, and Dr. Howard New, Deputy Chief Public Health Officer. Also accompanying me are Ms. Cindy Evans, Vice President, Emergency Management, Stephen Bent, Acting Vice President, Vaccine Rollout Task Force, and Ms. Jennifer Lutfala, Vice President, Health Security and Regional Operations. So since we last provided you with an update, there have been significant changes across the country. However, one thing has stayed the same. COVID-19 is still circulating widely. Disease activity remains high in Canada, and the BA2 sublineage now accounts for more than 90% of sequenced variants. However, there are early signs that transmission may be nearing a peak in some jurisdictions. We expect further ups and downs over the coming months, but maintaining a vaccine plus approach can provide us better protection going forward. This means continuing to take personal precautions like masking, improving ventilation, and staying home when we have symptoms or test positive. It also means maintaining a strong core of protection against severe illness by getting up to date with COVID-19 vaccines, including booster doses. And it is crucial time to ensure that we and our loved ones are up to date on routine vaccination and catch up on any that have been missed or delayed over the pandemic. Vaccinations help keep us healthy from childhood through to adolescence and into adulthood. As of January 2022, over 74 million total doses of COVID-19 vaccines have been administered in Canada. I'm pleased that the number now stands at more than 83 million. Nationally, more than 89% of eligible Canadians, which is 5 years of age and older, have at least one dose of COVID-19 vaccine. Approximately 81% of the population has received 2 doses, and as of April 29th, more than 18 million Canadians have received a booster dose. At this time, National Advisory Committee on Immunization strongly recommends a first booster dose for adults 18 years of age or older and adolescents 12 years to 17 years of age who are at higher risk of severe outcome or exposure. In addition, NACI recommends a first booster dose may be offered to anyone aged 12 years or older in the context of heightened epidemiological risk. NACI is also recommending that the second booster dose be rapidly deployed and prioritized for those who are expected to benefit the most, namely the residents of long-term care homes and other congregate living settings for seniors, and to seniors 80 years of age or older living in the community. At this time, just to mention, Canada has sufficient supply of mRNA booster doses for all eligible Canadians. On the international side, the international outlook of COVID-19 has shifted. So too has our approach at our borders. When I last appeared, everyone coming to Canada had to be tested for COVID-19 prior to arriving at the border. However, on February 28th, we expanded the options for the pre-entry test requirements. And then on April 1st, we removed this requirement for fully vaccinated travelers. As of April 25th, we removed the pre-entry testing requirements for unvaccinated or partially vaccinated children aged 5 to 11 who are accompanied by a fully vaccinated parent, step-parent, guardian, or a tutor. Pre-entry tests are still, however, required for partially vaccinated or unvaccinated travelers 12 or older. We continue to monitor our borders and assess risk, and our measures remain flexible and adaptable, so we are prepared for future scenarios. Nous sommes durant de la pandémie. Nous passons.
To prepare for the future, we are committed to working. We have to prepare ourselves for future waves and also for possible worst-case scenarios. I encourage everyone to keep their COVID-19 vaccines up to date, including getting a booster as recommended. Be aware of the risks in your community and maintain individual protective practices, such as wearing a mask and staying home when sick. Together, these measures will help protect us as we move forward. Thank you.
Thank you very much, Dr. Kochar. We're now going to begin rounds of questions, starting with the Conservatives. Mr. Barrett, please, for 6 minutes.
Thanks very much, Chair, and thanks to everyone from the Public Health Agency of Canada who are here today. Thank you, Dr. Kochar, for your opening remarks. You spoke about the change to entry requirements that were enacted recently, and I'm wondering if there is any documentation, perhaps a decision tree or established benchmarks that were used to arrive at that decision and that is being used to monitor with respect to making future decisions. And Doctor, if such documents exist, would you be able to table them with the committee? I don't think your mic is on,
mute,
sir.
Doctor.
I'm sorry, Chair. Apologies. Chair, so what I was trying to say was that we have continued to monitor the epidemiology, the vaccination rate in Canada, and the available tools with us, for example, availability of therapeutics like Paxlovid, and these are all taken into consideration as we relax our border measures, and those are the components which we take into consideration while we change our border posture.
Well, thank you, Chair, and thank you, Doctor, for that response. So I'll just leave it open-ended, sir. If following your appearance today, if you or your staff find that there are documents that you believe would be helpful for informing the committee and Canadians with respect to that decision-making process that get into maybe a bit more granular detail, I'd very much invite you to submit those to the committee. Now, testing requirements for incoming international travel remain in place more than 2 years into the pandemic. This has created pretty serious bottlenecks at Canada's largest airports, including significant aircraft holds on the gate and delays offloading passengers. This worsens Canada's ability to attract tourists, which has downstream impacts on trade and investment relationships with other countries, our allies and partners. So what is the Public Health Agency of Canada doing to update or remove legacy processes at the border, including international arrival testing, to ensure that these backlogs do not occur during the peak summer tourist season and beyond, because we're certainly seeing those backlogs right now?
Mr. Chair, I'd invite my colleague Jennifer Lutfalla to respond, as she's been managing the border operations.
Thank you, Mr. Chair. We are aware of the gate holds that have been occurring across the country. There are a number of factors that are contributing to those gate holds. So in terms of your question with respect to testing, as you are aware, we have moved over to an MRT system, which has significantly decreased the number of individuals who are being tested at airports, thereby reducing the number of people within those airports. Unvaccinated individuals, as you know, continue to be tested via our border testing program. As I understand, there continues to be issues with respect to individuals who have not completed a ArriveCan, which has led to individuals being referred over to FAC, thereby creating bottlenecks, if you will, within the airport. We are working with our federal partners, as well as airport authorities and airlines, to ensure that those individuals, in fact, complete their ArriveCan prior to boarding the flight, thereby reducing the volume of individuals within those airports. We're hoping that these measures, as well as others that we continue to assess with CBSA as well as Transport Canada, will get us ready for the summer period.
Well, thank you, Chair, and thank the witness for the response. So in addition to it slowing down people's arrival, we've also been starting to see the emergence of evidence that this type of arrival testing is not effective. And I'm seeing that there are few countries that are actually continuing to employ arrival testing. So I'll ask two questions because I have about a minute and a half left. So why is PHAC continuing to pursue this particular method? Controls are important, but why are we continuing with this one at Canada's biggest airports? And I guess my other question, if we can fit it in what will be a minute for you to respond, is that wastewater testing is a better early warning tool than arrival testing. And so I'm wondering if PHAC is undertaking steps to expand the use of wastewater surveillance.
Mr. Chair, let me start by mentioning that the post-arrival testing is actually a very important tool for us to monitor the prevalence of COVID-19 in fully vaccinated travelers arriving, and specifically to monitor new variants, which might be of concern, because that is how we track them and we can actually take action. And also, we identify travelers for whom compliance and enforcement activities are required, so that if they're not actually vaccinated, they are directed to DQFs, or they are directed to do day one and day tests. So that is an important piece for us in our programming. Wastewater testing is a tool which we have been using in the cities, where we are using a lot of stuff which is major cities have actually been able to test those wastewater, and gives us a signal, early warning signal, what is circulating in those communities, and accordingly the individual choices as well as the community availability of the tools, they can be upped, as for example, making sure that there is masking, or making sure that individuals take particular precaution when going into a community cumulative setting onto that. So wastewater continues to be a part of our toolkit as we move forward.
Thank you, Dr. Kochar. Mr. Barrett, next we're going to hear from Ms. Sidhu, please, for 6 minutes.
Thank you, Mr. Chair. Thank you, all the witnesses, for being here with us. My first question is to Dr. Tam. Dr. Tam, this pandemic has had significant impacts on mental health across the population. If we can see seniors, they have a social isolation. Youth is also impacted. How we can better address the mental health of Canadians, especially for certain vulnerable populations.
For her question, this is an extremely important question because mental health is, of course, very important as the overall health for the population, even before the pandemic. Is something that we have to address in a more concerted manner. But the pandemic has had really significant impact on the mental health across numerous populations. Not just because people are worried about the virus, but it's compounded by the impact of the disruptions to our lives, our work routines, financial stress, social isolation, of course, grief and bereavement because of the loss of loved ones and reduced access to available services and supports. And these impacts have been particularly acute for certain groups, including frontline health workers who've experienced worsening mental health conditions during the pandemic, and racialized Canadians and others who've been impacted by the social determinants of health and inequitable access to services. So I think this is a big issue. And of course, the concurrent and parallel and worsening opioid and other substance use overdose crisis. So I think the response to this has to be multifaceted. By the way, we have had some innovation and new approaches that I believe will benefit mental health during the pandemic and also to come. For example, the Wellness Together platform and PocketWell has allowed numerous Canadians, including youth, to have access to more real-time services as part of so-called step care as a range of measures. But I believe the budget 2021 provided funding, $10 million over 3 years for the Public Health Agency itself to support projects that would promote mental health, especially those most impacted by the pandemic. And as I said, because health workers and frontline essential service providers has been severely impacted by PTSD, that's post-traumatic stress disorder and trauma, there was money, $50 million provided over 2 years starting 2021. These projects are beginning in the spring. I hope it is spring now. And so we want to be able to look at how these diverse programming can support our frontline workers who have been burnt out and impacted. Of course, significant investments on Kids Help Phone, as well as the capacity of the stress centers have been augmented and additional funding to the Canada Suicide Prevention Service.
Thank you, Dr. Tam. The next question is about the vaccination. Still, data shows there are gaps in coverage for COVID-19 vaccination. Recently, the Minister of Health came to Peel to visit the Medical Officer of Health, Dr. Lawrence Lowe, and we had a conversation about how to continue encouraging Canadians to get vaccinated. How do you think we can continue to encourage Canadians to get vaccinated against COVID-19?
Thank you for that question, Mr. Chair. I think that vaccines remain a cornerstone of our ongoing management of COVID-19. And it is really important to continue to encourage uptake of the first 2 doses, but also the boosters that we now call up-to-date vaccination. I think there's a number of reasons why, for example, the booster rates are not as high as the first 2 doses. And we need to be able to understand better and address those issues. I'm sure when you're on the ground in Peel and some of the local health units, they'll talk about the different challenges experienced by different population groups. There's certainly a lack of trust in policymakers and public health officials and governments by certain groups that have been experiencing inequities. Complacency, people thinking that 2 doses is enough, when we know that with the arrival of the Omicron variant, you need to get up to date with a booster dose when eligible. convenience and access is still a issue for many. And so local public health has been using many different measures to try and improve access, mobile clinics, getting pharmacists. Thank you, pharmacists, for providing your support to getting vaccines into arms. And I think a lot of different information and misinformation also doesn't help. So providing the credible information through healthcare providers is a really important component, and one that the public health agency has been supporting the healthcare providers with credible information so that they can counsel their clients. I think because of the trust issue, we've been trying to enable local leaders in their communities, including faith leaders and other trusted leadership, in order to augment trust and vaccine uptake. So I think you need a multifaceted approach like we did in the first 2 doses. And just a reminder that if you had recently had COVID, you can get a vaccine. It's recommended that you wait 3 months before you get a booster. But Omicron virus itself may not provide consistent protection against further infection. So it's also important to stress that point. For parents, I think that the uptake in the 5 to 11s could be better. And I just want to reassure parents that over 3 million kids already receive vaccines in Canada, or 3 million doses have been provided. There's no safety signals. Many children have been vaccinated around the world. So we encourage parents to seek answers to the questions and get their kids vaccinated.
Thank you, Dr. Tam. Ms. Sidhu, suite, c'est le tour de...
Mr. Garon, you have the floor. Thank you. Thank you to our guests. Thank you for being here. Dr. Tam, when I look at people's reaction with regards to vaccination, the situation has changed a lot. There seems to be more confusion than in the past with the issue of vaccination. And I think that each booster dose, people say, oh, well, I thought the first booster dose would be enough. And sometimes they're surprised that they need a 3rd booster dose and even a 4th. And so... Mr. Garon, I'm sorry to interrupt you.
Ringing. We're obligated to suspend the meeting unless there is unanimous consent to proceed for a period on which we all agree.
Mr. Chair.
What's the pleasure of the meeting?
Mr. Chair, I would say that we would consent to complete the first round of questions.
Okay, so Mr. Garon, Mr. Davies. Okay, Mr. Garon, vous pouvez continue until Don's finished his turn. Thank you. Vous pouvez...
You can start again, Mr. Caron. Yes, I'll start again very quickly. When we're talking with people, when we look at the media and the attitude with regards to vaccines, we see that people are very confused with regards to vaccination. And they thought that after a vaccine and a booster dose, it would be enough. Then they need a 3rd booster dose. Then they're surprised they might need a 4th booster dose. And today, what we're seeing is that there's a lessening of trust among many Quebecers and Canadians. Each person now has their own theory on how long a vaccine protects them for, on their efficiency, etc. What can we do and what is being done in order to improve communication, this communication, scientific communication, and would it not be appropriate to announce to Quebecers and Canadians what will be the frequency of booster doses? What's being done on this type of communication at PHAC?
This question. That is a very important question. Of course, we are learning about both the virus and the vaccines over time. So the duration of the protection of the vaccine, which we've seen as extremely good with 2 doses of vaccine at the start, really shifted when the Omicron variant appeared. So there's changes in the virus itself. So I think it's really important to provide Canadians with up-to-date information as we have it. And Health Canada and its authorization of vaccines, including boosters, and the National Advisory Committee on Immunization will adjust their recommendations with the increase in knowledge. So I think that's what we've been seeing happen over time. And I think Canadians really rolled up their sleeves and got the first 2 doses. I think there's an increase in understanding that boosters are important. All the chief medical officers and the National Advisory Committee on Immunization came out again strongly, given the evolving evidence to say, if you're 18 and over, go get boosted. Even if you've been infected, wait 3 months, go get boosted. That is a much clearer message, I think, than when we were still trying to learn the impact of Omicron and the booster doses. So I think that's a very clear message, and that I hope all Canadians will get boosted. But we will keep learning as we're going along. We are preparing for any potential re-emergence of different variants, and we have to check the effectiveness of vaccine against those as they emerge. We cannot know that ahead of time. And we also have to prepare ahead of time for a potential for a fall-winter respiratory season, during which Canadians should bear in mind that governments will likely come out to recommend additional doses as well. So I think the most important thing is to keep the communication channels open, and as I said, capacitate healthcare providers and other trusted leaders in providing the credible information.
Merci beaucoup, Dr. Tam.
Thank you, Dr. Tam. Now, on another issue. We see the arrival of summer. We see tourism is starting up again, and we see that travelers are starting to travel again. That's great. We're very pleased about this for our economy, for our regions. At the same time, we know that all these issues around health restrictions, this is provincial jurisdiction, and sometimes this has eroded social cohesion, and sometimes we are hesitant in imposing new measures. How do you foresee the months to come, the summer, the fall? What are your thoughts on this? How will the pandemic evolve? What's the trajectory? I know you don't have a crystal ball, but how do you see the next few months?
Well, I think at the moment we've, together with the other chief medical officers, I've been characterizing this period as a transition period where we hope we're past the extreme acute phase, the crisis phase of the pandemic, but we're on the road to a more steady state. We're not there yet. So there's unpredictability in the timing of the waves, what variants might come along. There may be seasonality to this virus, and that will go up and down like influenza, but we don't know. We have to keep our surveillance and our information channels, as I said, going throughout this fall and winter season and reevaluate at the other end. But the good news is, I think, with the high vaccine coverage as a whole, we need the boosters, of course, but the high level of immunity, you may have seen some of the results, post-Omicron wave means that globally and domestically, there is an increase in population level of immunity. So that is good in terms of the chances of us being able to keep society open. But going forwards, I think what's important is preparedness. Get prepared for a potential nasty variant that's going to come along that's not only highly transmissible, but can cause a severe outcome. And be prepared for that scenario. Otherwise, I think we now stand a better chance of gaining some of that normality back. I would say that Canadians who have learned all these different great public health measures, personal protective measures, should consider keep on going with those layers of protective measures that they can put on, not just for COVID-19, but for influenza and other respiratory viruses that are making a comeback. So it's a matter of developing these personal habits to try and reduce the need for escalation of the more restrictive public health measures.
Merci, Mr. Garon.
Thank you, Mr. Garon.
6 minutes.
Thank you, Mr. Chair. Thank you to the guest for being here. Dr. Tam, on April 12th, a little over 2 weeks ago, you said the following: it depends on the location, but yes, we can say we are experiencing a sixth wave in Canada, generally speaking. There has been a rise in COVID-19 activity everywhere. Dr. Tam, have we reached the endemic phase of COVID-19 in your view?
In my view, no. As I've just said in my last response, we are in a transition phase. An endemic period is where we have much more predictability on the pattern of this virus, and we can then anticipate a more regularized response, if you like. We're not there yet,
Okay.
so I think we just have to be careful. And
Thanks.
yes, we are still experiencing that BA2 sixth wave.
Thanks, Dr. Tam. In your view, is it premature to lift federal mask mandates at present?
That is not my decision to make, but I would encourage, whether there is a mandate or not, everybody should continue to wear masks in indoor public settings when you're not with people that are in your household.
Well, if I may, you're Canada's Chief Public Health Officer. If you don't know, I don't know who else we ask. So I'm going to ask you again, is it premature to lift federal mask mandates or not? Yes, no, or you don't know?
At the height of a sixth wave, no. I don't think we should be lifting mask recommendations or
Thank you,
mandates.
Doctor. Dr. PHAC's most recent epidemiology and modeling update, released on April 1st, a month ago, outlined both a realistic scenario for the future, defined by ongoing transmission with intermittent waves, as well as a worst-case scenario, defined by the emergence of an immune-evasive and severe virus of concern, which I think you've mentioned. In your view, Dr. Tam, what is the likelihood of the worst-case scenario coming to fruition?
I think that's unpredictable, because in that scenario, you can potentially have a virus that goes somewhat under the radar, maybe developing in an immunocompromised host.
Dr. Tomlinson, let me clarify my question. I know it's unpredictable, but I'm just wondering, this is your modeling. I'm just wondering, has PIAC put a number on it or quantified that in some sense, or is it completely, you have no idea whatsoever? I'm just trying to find out if PIAC has put some sort of projection on whatever the likelihood of that might be.
I don't think we know the probability, and that's not modeling, that scenario planning. Just to clarify that particular presentation, you have to plan for both of those scenarios, and we don't really know, but I think it definitely could happen, and we need to plan for it.
Thank you. Now, earlier this month, Health Canada confirmed that almost 1.5 million doses of COVID-19 vaccines held in a national inventory have expired since January. Now, we had a problem with expired personal protective equipment early on in this pandemic. Given that Canada has only donated 14.2 million surplus vaccine doses of the 50 million it promised to deliver to the COVAX facility by the end of this year, why were these doses allowed to expire?
Mr. Chair, I would suggest to take that question. So thank you very much for the question. FAC works very closely with provinces and territories to ensure procurement and allocation strategies align with the requirements and demands for individual jurisdictions. When there are doses surplus to Canada's need, Canada makes every effort to make them available to countries through COVAX with sufficient shelf life. Canada has committed to donate the equivalent of 200 million doses to the COVAX facility by the end of 2022. While the priority will be to place doses to be donated through COVAX, Canada also works for all other potential avenues, including through multilateral and, if necessary, bilateral donations to ensure vaccines can get to those who need them most. We are also working with the COVAX facility. And
with respect, Mr. Bent, I've limited time. If you're not going to answer my question, then I'd rather you just say so. The question I asked was why the 1.5 million doses were allowed to expire, not what arrangement you have with the provinces or COVAX.
Thank you for the question. We work very closely with Global Affairs Canada and international bodies like COVAX to make available doses as soon as we can so that they can be used if needed by other countries. And we have made doses available to COVAX, and they are in the process of identifying countries that can take them.
Thanks.
If no suitable country is identified, the doses are then retained by us until they expire.
So are you saying, sir, that no suitable country was identified to Canada, so we chose to let 1.5 million vaccine doses go expired because we couldn't identify any country that needed it? Is that what your answer is?
I would offer that we continue to work with COVAX to identify potential countries that could take the doses, and offers as much lead time as possible.
Thank you. Dr. Koshar, to you. You talked about being up to date, and you gave an example of the flu vaccine. I'm curious about the efficacy of a third or even a fourth booster. Help me understand this, and forgive my ignorance if I don't understand this correctly. The mRNA vaccines were developed to respond to the spike protein on the first version of COVID-19, which was the alpha version. We have immune escape variants, which by definition are mutating away from that. We've gone through beta, delta, gamma, omicron, and there's others. Can you help me understand how giving a booster which boosts antibodies to recognize the original spike protein of the alpha variant can help produce effective immunity to a virus that has significantly changed since that time?
Dr. Tam, Mr. Davies is out of time, but if you could provide a concise response, or if it requires something longer, maybe respond in writing, but go ahead with a couple of brief comments, please.
Yes, and this is Teresa Tam. I'll take that question. Despite the change in the spike protein through different variants, up until Omicron, 2 doses of vaccine retained really good vaccine effectiveness against the most prominent ones, even though we were monitoring for waning immunity. When Omicron arrived, even though it looked significantly different from the Delta and preceding variants, a boost actually through our vaccine effectiveness estimates provided at least an initial protection of 60% against infection and symptomatic disease as a range, and over 90% vaccine effectiveness against severe disease with the third dose. That could wane over time, but that's still good news.
Thank you, Dr. Tam. The meeting is suspended, and we'll see you after votes. Call the meeting back to order. Thank you, everyone, and thanks to our witnesses for your patience. We are going to we're going to continue on until probably 6 o'clock, unless there's a motion to adjourn that is accepted by the committee. So we have about 45 minutes. We're going to recommence questioning, and the next person to pose questions is Dr. Ellis for the Conservatives for the next 5 minutes. You have the floor, Dr. Ellis.
Well, thank you, Mr. Chair, and thank you to the witnesses for your patience of the shenanigans of government, unfortunately. That being said, to get right to the matter, Dr. Tam, I'm wondering, with respect to some of the questions that were asked previously through the chair, would it be in the interest of PHAC, would you submit a decision tree with who would make decisions in the Public Health Agency of Canada? We've had some difficulty understanding who makes the decision, and if you would submit that in a simple form, that would be excellent. And secondly, would it be fair to say that it's the Prime Minister who makes the final decision with respect to federal mandates? Simple yes or no answer, ma'am.
There'll be a cabinet decision.
Cabinet decision, right, okay, fair enough. That being said, as I said, I'd love to see your decision tree in a page. That would be great if you would send that to us. With respect to federal employees and mandates related around their perhaps lack of vaccine, I'm trying to understand what benchmark and metrics you might use. We've asked this question multiple times. Let's just focus specifically on those unimmunized federal employees, perhaps a federal scientist who works by him or herself. What would be the harm in them working alone? I can't see any, perhaps. But secondly, what are the benchmarks, the metrics going to use to allow them to return to work, those folks who have been unimmunized?
Maybe I'll start before I pass it on to Dr. Tam. In relation to the federal vaccination mandates, we have really actually focused on multiple factors. As I mentioned earlier, global and domestic epi situation, vaccination coverage, as well as what is the new variant of concern circulating, availability of rapid tests, as well as availability of different therapeutics. All of these things guide us to really see how far we can take it in terms of our ability to have those who are vaccinated come to work. And again, at this point, this is a function of Treasury Board Secretariat, specifically on the federal vaccine mandate. And we have almost 99% coverage for the public service employees, at least.
Well, thanks, Dr. Co-Chair. I appreciate that. We've heard that multiple times. I guess I find it a bit contemptuous that nobody's willing to specifically release what those benchmarks are. Clearly, you've just said that you have them, and I'm going to be so bold as to say there are 3 physicians on this committee, and not to be downplaying the work of my other colleagues, but oftentimes we're told that this complicated science can't be explained. I find that hard to believe, and clearly you are using some sort of science. Would you be so kind as to table that here to the Health Committee? The science you're using, you have to have some. You just said you did. Can we see it? Simple yes or no. Can we see it? Yes or no?
We continue to actually
Sir, I'm going to interrupt you because I don't have much time left. Simple yes or no. Can we see the benchmarks, the metrics that you use? They cannot be that complicated. Just send me the ones on federal employee mandates who can return to work without being immunized. Does that exist, and can we have it?
My simple answer is that we do take a number of factors into consideration, Mr.
Right,
Chair.
so tell me what they are, and please give me the list of them. That's all I'm asking. You know what they are because you use them, so I would like to see them on behalf of Canadians who, as Dr. Tam said, are lacking trust and have gained complacency. So could you please give me the list of benchmarks that you're using? You have them. I know you do. You just said you did. Could we have them here at committee, please? Simple.
We would take that as a remittance, Mr. Chair.
I'm not sure what that means. Is that a yes or no?
To bring it, we will attempt to put that all together for your consideration in a written format, Mr. Chair.
You will table that in writing to this committee?
Yes, Mr. Chair.
Why, thank you very much. Wow, that was just lovely. I really appreciate that. I've got no time left, so thank you, Mr. Chair.
Yeah, but you got what you were looking for, Dr. Ellis, so thank you for that. Mr. Vancouvernan, please, for 5 minutes.
Thank you, Mr. Chair. I'd love to hear from our witnesses, so I'll try to keep my question brief. My question to anyone who's prepared to answer is with respect to arrival positivity rate. And I'm just curious if when folks arrive at various ports of entry, if that post-international travel positivity rate has at all mirrored or resembled or perhaps even predicted future increases in cases domestically here in Canada. Has our arrival testing supported the prediction of cases in Canada?
So, Mr. Chair, I'll start in terms of the positivity rate. It has varied over time. I have the latest stats. For example, in April 10th to 16th, the test positivity rate among the fully vaccinated travelers was almost 3.27% in the air mode and 2.7% in the 2.4% actually in the land mode. And again, we compared it with partially non-vaccinated traveler, where the test positivity rate was again 2.25% in air mode and 5.8% in land mode. So what it depicts is that we continue to look at border test positivity rate, which remain considerably higher than those prior to when Omicron first emerged. So that is a way to for us to make sure that we continue to monitor the incoming travelers for their positivity rate, so that we can make adjustments to our public health measures.
Thank you, Dr. Kochar. So, if I'm understanding it, what you're saying is that the incoming travelers are still testing positive at a higher rate than the general population for COVID-19?
So, if I may, yes. So, if in terms of the positivity rate, as the president has pointed out, he's provided you the positivity rates. It tends to mirror what we've been experiencing on a domestic level in terms of the trends. So, during the Omicron phase, we saw a fairly substantial increase with respect to positivity for those travelers who are arriving at particularly at the land port of entry. So in terms of your question, the trend seems to be the same.
Thanks. That's what I was interested in knowing, is if the test positivity rate at the border was resembling increases domestically. The second half of my question is with respect to the disproportionately high volume of children under 5 who have been admitted to hospital lately. It's pretty alarming. The numbers are high. I think the last time I saw the children under 5 represented the third highest age category, and which is shocking considering there's only 5 years in their age category, and some of the other age categories are like over 60 or over 65. Any reflections on what's necessary to ensure that the youngest and most vulnerable members of our community are protected from COVID-19?
Yes, this is Teresa Tam. Mr. Chair, I'll take this question. And that is correct. We are seeing some of the highest rates of infection as well as hospitalizations in the very young. So the most senior populations still have the highest risks. But not surprisingly, I think the younger children, if they get sick, they have smaller airways, and just as with other respiratory viruses as well, is that they can get more sick compared to others as well. Of course, as we all know, they are not vaccinated at this point, the under 5-year-olds. I think it's good news, at least, that one manufacturer, Moderna, has submitted their application to Health Canada. So we hope that they too will benefit from vaccination as a form of protection in the near future. But others can help protect this age group as well by doing all those other layers of measures that I've talked about so often, by getting vaccinated themselves, the parents, the older children, people around them, and also other layers like masking in order to reduce transmission to that age group.
Thank you, Dr. Tam. And Mr. Vancouverden, ensuite Monsieur Garon pour 2 minutes et demie.
Merci.
Thank you. Dr. Tam, is it correct to say that most of the new variants that we're facing are coming from countries, oftentimes developing countries, where the vaccination rate is extremely low? And in this context, if that's true, are international efforts made to increase vaccination in those countries, including in the Canadian effort? Is this sufficient?
Thank you for that question. Merci pour la question. And I think the most important thing is the global surveillance system, as you've said. Because surveillance has improved, genomics has improved, we are able to monitor these variants. Yes, it's quite possible for these variants to come from countries that have lower vaccination rates. But I think this virus is evolving as we exert pressure on this virus from an immunological perspective, whether it's from the vaccine or from prior infection. The virus will continuously adapt, and it may come from a country with higher bulk of viruses and transmission. That is true, but we have to remember that the virus can come from maybe all of a sudden from a place that you don't expect. Including maybe generated from an immunocompromised host.
Le temps nous étant compté, ma question est...
Dr. Tam, my question is the following. If the efforts to vaccinate all of these countries that don't have the means, such as G7 or G20 countries, do you think these efforts are sufficient right now?
I think more needs to be done, not just the provision on the amount of vaccines, is being able to support the vaccination of the population. There's trust, there's other issues, and as to why these vaccines are not being used, actually, the supply is outpacing demand at this moment. I know that refers back to another question that was previously. We need to better understand and support other countries and their population and support their local jurisdiction in increasing vaccine uptake. So it's not just a matter of supply.
Merci, Monsieur Garon. Next, Mr. Davies, please, for 2.5 minutes.
Thank you, Mr. Chair. Dr. Tam, last week, WHO Director General Tedros Adhanom Ghebreyesus said the following at a press conference. As many countries reduce testing, WHO is receiving less and less information about transmission and sequencing. This makes us increasingly blind to patterns of transmission and evolution. But this virus won't go away just because countries stop looking for it. It's still spreading, it's still changing, and it's still killing. When it comes to a deadly virus, ignorance is not bliss. WHO continues to call on all countries to maintain surveillance. Dr. Tam, given that many provinces and territories scaled back access to PCR testing after the emergence of Omicron, do you believe that Canada currently has a sufficiently robust system in place to monitor COVID-19 activity and the emergence of new variants of concern?
Thank you for the question. So, Mr. Chair, I think, yes, the number of tests, and by that I mean PCR tests, being done around the country has been reduced. But, of course, rapid tests has come into play. We don't have samples from those rapid tests in order to look for variants or sequencing. But there are quite a lot of samples being done every day from which we can do sequencing on. And we are still sequencing at quite a high rate, at a rate that we can detect the more rare variants. But we need to keep this up. And, of course, add the wastewater surveillance. Actually, on top of doing viral copies, use metagenomics to look at variants in the wastewater.
Thank you, Dr. Tam. Dr. Tam, you touched on this a bit in my last round. I'm curious about whether the protection offered by mRNA vaccine third dose boosters, is that waning at a similar rate to second doses?
Yeah, we, of course, have to observe this over time because many people got boosted more recently. What we're seeing is that third doses does increase protection against infection or symptomatic disease and therefore transmission, but that does decline over time. And we're just trying to plot to see how fast that waning occurs, but we need a bit more time, but it does decline. And so you can still get potentially infected. But the vaccine effectiveness against severe disease was boosted to very high levels of over 90%. And even over time, that's just gradually decreases. So we need more time to figure out the duration of protection. But it does seem to be quite good at the moment, but we'll certainly provide further updates as time goes on.
Thank you, Dr. Tam and Mr. Davies. Next, Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all of the witnesses. It is wonderful to have you guys appearing before committee. So one of the biggest questions that I frequently get into my constituency office in my beautiful riding of Fort McMurray Cold Lake is questions as to when we are going to see mask and vaccine mandates for the federally regulated sectors removed. And I know we've had many people ask questions about what the targets are, but I'm wondering what you think I should be telling my constituents when they call and ask those questions.
Mr. Chair, as I mentioned earlier, for the federal vaccine mandates, it is, for example, the Treasury Board of Canada, which is responsible for the policy on the vaccination, for example, for public service. And again, all the elements of the policy and other aspects of the public health aspects are being reviewed by them. And this is all based on science and advice.
And so, that's fantastic for the public servants. But for myself and in my riding, being a northern riding, we basically have to fly to get just about anywhere. So there are requirements by the federal government and PHAC that require proof of vaccination for people. If they want to go to a funeral in Toronto, if they're not vaccinated, they can't go. And so they're really curious to know when you guys are going to update this, because no other allied country is requiring people to be vaccinated to travel within their own country. So are there any targets in place for that?
So, Mr. Chair, what I can say is that we are continuously evaluating what is the epidemiology, what is the vaccination coverage, and what other public health layers can provide the protection. And this is an active conversation which we're having in terms of the public health advice as we move forward, so that a particularly a science-based decision can be made on that.
Fantastic. Well, just so you guys are all aware, and I'm going to share this, it is more than 3,600 kilometers to get from Fort McMurray or Cold Lake to Toronto. And I'm going to use Toronto as an example because you guys are aware of that. And I have numerous constituents that contact me because they want to go, because they're not typically from those communities. They're from somewhere else. And unfortunately, they'll have parents that get sick and they need to get on a plane. But because of the rules of this government, they can't get on the plane to go visit their parents in their dying days. I'm asking for some compassion, understanding that many people in rural and isolated communities have different needs than those in urban centers. They can't just get in a car and quickly get there. And so this is really impacting the lives of everyday Canadians in communities just like my riding and all across northern Canada. So can you do anything special to make sure that that is being considered?
Mr. Chair, my heart goes out to those, communities which are unable to attend to the family and, other aspects of their daily life. And we are committed to provide that advice for getting to the point where we can have an appropriate decision based on the public health guidance, as well as the ability to still protect the population from transmission of COVID-19. And we continue to work towards that goal.
Could you guys at very minimum then perhaps look at simplifying the process for people that have medical exemptions that have been exempted by doctors and physicians? I had one constituent who is a nurse and has an anaphylactic allergy to vaccinations, and the process that was required to get her to be able to get on a plane was so onerous and so time-consuming, she almost missed her father's funeral. And this was someone who has served us as a nurse on the front lines throughout the entire pandemic. These mandates are completely heartless. Can you at least look at something to perhaps provide some more clarity for those with medical exemptions?
Mr. Chair, and again, we continue to work with our colleagues with the Transport Canada, who have the mandate also in terms of this, domestic flight, and we continue to provide that kind of advice so that the decision can be taken to appropriately support and assist any of those such situations.
Thank you, Ms. Goodridge and Dr. Kochar. Next, we're going to go to Dr. Hanley, please, for 5 minutes.
Thank you, Mr. Chair. I'm wondering, is Dr. New still with us? Yes. Dr. New, just to perhaps mix it up a bit and change the theme, I'm just wondering what, in your mind, are some of the infectious disease priorities that may have suffered as a result of our necessary focus on the pandemic over the last 2 years, and how the agency is looking to address some of the backlog of work in some priority areas of infectious disease?
Well, thank you very much for the question, Mr. Hanley. Now, I can say yes, it's not just infectious diseases, but there's been many what I would call unintended consequences and collateral damage, obviously as a result of the COVID-19 pandemic, in terms of people accessing health services for other infectious diseases, as well as obviously for a whole host of, I would say, non-communicable diseases, mental health, et cetera. We all know that. The opioid crisis obviously is also a very important priority. But for infectious diseases, I would say that the ones that probably have suffered the most that we need to get back on track are the ones that I think are unduly sort of disproportionately affecting vulnerable populations. Those are, are marginalized, are racialized, are not able to sort of have the same resources to deal with certain infectious diseases like maybe many of us who are more fortunate. For example, I would point out tuberculosis. Certainly that's unduly the burden's been borne unduly by, for example, Indigenous populations, especially North and the Inuit, and certainly we continue to work with them. But obviously, in terms of the effort to take away from scarce resources to deal with COVID-19, to also address something like tuberculosis, that's certainly something we need to get back on track. There's also what I call the sexually transmitted bloodborne infections, HIV/AIDS. The global sort of, I would say, pandemic that's been long-lasting certainly isn't going away, and we need to get back to addressing HIV and all the other sexually transmitted bloodborne infections. And finally, I would say that another priority that we're making headway, but it's certainly something that we need to pay much more attention to in the future is antimicrobial resistance. COVID-19 is sort of the current very real pandemic, but I would say maybe a slower moving pandemic that if we don't pay attention, and you can see even the WHO has listed as, it's among its top 10 threats, it's something that's going to affect us down the road. Can you imagine a pre-antibiotic era if that were to return to Canada, where we're not able to use antimicrobials, antibiotics in the way that we're so used to at the present time? So just in a nutshell, those are some of the infectious disease issues that we're looking at. And of course, I could go on and on. There's also, things like climate change and how does climate change affect infectious diseases in terms of the spread and distribution of vectors. Lyme disease and others certainly have a much wider range now, and more Canadians are being affected because of, I would say, climate change. So you can see there's a wide scope, and certainly we intend to start addressing the other infectious disease threats in addition to obviously dealing with COVID-19 at the present time. Thank you.
Thank you very much, and I'm glad you mentioned antimicrobial resistance because it's certainly something we cannot turn our attention away from. And this is a question perhaps for Ms. Evans. I noticed in the budget 22, the agency has been designated over $400 million related to surveillance and risk assessment. And given that this is Emergency Preparedness Week, I was wondering if you could talk about how this funding might help to strengthen surveillance in a view of managing and responding and preparing for potential future phases of this pandemic, but equally as important, potentially other infectious disease threats and pandemics. As quickly as you can.
Oh, sorry.
Thank you.
Mr. Chair, thank you for the question. You've referenced certainly the funding that was referenced in Budget 2022, which would cover a broad range of activities, and we're quite pleased with respect to some of the steps that we'll be taking in terms of the early warning systems that we have that will be advancing a number of the issues that were raised in that external panel report. Certainly more broadly within the agency, as has also been raised, an interest in having a more integrated risk assessment, and that's some work that we will be able to advance through those investments that have been articulated, as well as looking broadly and horizontally across our surveillance programs to further and advance those. Thank you.
Thank you, Dr. Hanley and Ms. Evans. The colleagues, we have now completed 2 full rounds of questions. I'm advised that there are some members that have other obligations that they are anxious to get to. So we're in a situation where we have 3 options. We can entertain a motion to adjourn now. We can agree to continue on, as we do have the room and we do have the administrative support. And a third option that you may not have considered is to continue on with what's called a reduced quorum. So for those that absolutely have to leave, they can, with the assurance of knowing that we're operating under the rules of a reduced quorum, which prevents any motions from being presented except for a motion to adjourn. So I'd be interested to take the pulse of the room as to whether you wish to wrap, to continue, or to continue under a reduced quorum, because we do have the resources, but we have people with scheduling challenges. Mr. Barrett.
Thanks, Mr. Chair. If there was unanimous consent for a reduced quorum to be in effect, then I think that would satisfy the issues from Conservative members.
Do we have the agreement to continue for one further round of questions with a reduced quorum? Mr. Davies?
Mr. Chair, before I can answer that, I'd like to get some shape around what we're talking about. The committee would go until when? For those, the bloc and I, who have only ourselves here. We don't have other people to...
my understanding is that we have support until as late as 6:30. I guess I would suggest that we simply complete one more round of questions. So that would be 24 minutes from now, if everyone stays on time.
How is that divided? You mean each party gets 6 minutes, or
no? It would be the third round would be 5 minutes Conservative, 5 minutes Liberal, 2.5, 2.5, 5.5. Yes, go ahead, Mr. Lake.
If we just do the 5, 5, 2.5, 2.5, that takes us to 6, which is when you said we would end anyway.
Yep, we can operate under a reduced quorum with as such. So you get the last word, Mr. Davies. Surely that's satisfactory.
That's delightful, Mr. Chair.
Okay, so we are now operating under a reduced quorum. No motions are allowed except for a motion to adjourn, and the next round of questions will be posed by Mr. Lake for 5 minutes.
Thank you, Mr. Chair. In the original line of questioning by the Liberal member, she brought up mental health, and I believe it was Dr. Tam that talked about some of the expenses or the government spending in the recent budget on mental health. Just for clarity, exactly how much was committed in 21-22 for the Canadian mental health transfer in the recent budget? Is
Dr. Tam, did you want to answer that, or?
So that I believe I would have to consult Health Canada. That is not within the area that the agency has responsibility for.
just to be clear, nobody in the Public Health Agency knows how much was committed out in the Canadian mental health transfer in budget, the recent budget? In the Public Health Agency of Canada, nobody knows the answer to that?
Mr. Chair, I think what we have an information about is that there wasn't any specific to the mental health transfers, but there are mental health crisis support pieces which over the budget 2021 and other pieces which we have, incorporated into the mental health support.
So just to be clear, as I'm looking, because I've got the Liberal platform from a couple of months ago when we had an election, like just a few months ago, and it promises $4.5 billion towards a Canadian mental health transfer. And in the costing of that platform, it's very clear, 21-22, this is just a couple of months ago, promises $250 million for 21-22 in the Canadian mental health transfer. Am I making a mistake in reading the budget, or where is that $250 million committed? It was just promised a few months ago in election.
I think this would be something which we'll have to discuss with our colleagues in Health Canada. Mr. Chair, if you would prefer, we can come back with a written answer on that one, please.
That would be great. Could I just get some clarity? There was some question earlier about policy decisions. Would a decision like this be a decision made by Health Canada or the Public Health Agency of Canada, or would this be a decision made by the Cabinet? The decision not to fund $250 million for a Canadian mental health transfer that was promised in the Liberal election platform just a few months ago?
So my understanding would be that this would be something which would be discussed in the Cabinet. We provide advice on that, but Mr. Chair, I am not sure that I would be able to answer that question straightforward on that.
Okay, and then the one final question I would have is, in your knowledge of the NDP Liberal agreement, and perhaps the NDP member who's at the table here could answer this question. I'm wondering if the NDP members of the coalition, or whatever their agreement is called, if this was something that they agreed to when they made their agreement to not include the $250 million transfer for the Canadian mental health transfer. Don, do you want to handle it?
Sure, the answer is no.
Okay, thank you. I'm done. Thank you, Mr. Chair.
Thank you, Mr. Lake. Next, Dr. Pawlowski, please, for 5 minutes.
Thank you. So Dr. Tam, Dr. New, myself, Don have been at this for a long time. You're all public health experts, and I'm not telling you this story for your knowledge, but for some of the people in the committee room who aren't familiar with this story. So every public health class probably starts out with this story of London during the 1800s, and there's a cholera epidemic, and Dr. Snow, this very wise doctor, decides instead of treating people, we should prevent them getting sick. So he puts a lock on this well in the middle of London, and thereby prevents and stops this cholera epidemic. And that's used as the example of how prevention is so much better than treatment. And it's a lot more efficient, it's cheaper, it's a better way of doing things. So using public health, so far we've done an excellent job, using things like vaccination, social distancing, and I gotta say, Public Health Agency of Canada leading us. The Canadian people have done very well. We've had a third of the death rate of the United States, about half the death rate of countries like France and Italy, Germany, using those public health measures. But I think it's come at a cost. It's certainly come at a cost in terms of the national debt. It's come at a cost in terms of mental health. It's come at a cost in terms of civil strife. And I wonder, and I'm asking you this question, whether we ought to start to be looking at changing direction. We've whipped the public health horse about as hard as we can whip it. Maybe we have to start changing a direction in terms of trying to place measures to prevent people getting really sick. And that means protecting the elderly with third doses or fourth doses of vaccines if necessary. And the other thing is possibly doing better in terms of treatment. So we do have pretty good treatments in terms of Paxlovid, in terms of remdesivir for treatment, which really aren't being used that much. The public largely doesn't know about them, and people don't know if you're high risk and you get sick, perhaps you should get treatment. So, and maybe we've come for full circle. So normally, yes, public health is cheaper and a better way of addressing a problem, but perhaps we're starting to look at maybe treatment is perhaps starting to become almost a cheaper thing to do. So I'd like to ask your opinion about that. Should we be doing more in terms of treatment, protecting the really vulnerable, and worrying maybe a little less about the costly public health measures?
Thank you for that question, Mr. Chair. So I think at this period, 2+ years into the pandemic, with vaccine in hand, even though we're still learning about it, I think there's a much better chance of getting that balance. And that's what the chief medical officers across the country are trying to do. You're trying to balance the impact of the pandemic, but also try to reduce the negative impacts of some of those measures. And I think the easing of those public health measures is occurring across the country, with the view that unless it's really, really necessary, you're going to rely on the least restrictive of those public health measures like mask wearing, etc., in order to reduce the impact. But treatments do play a role in reducing severe outcomes and preventing those with the highest risk who may not respond as well to vaccines. So it is a complementary measure, but vaccines still remain, I think, as a preventive tool, one of the most important aspects of our ongoing management of COVID-19.
So I take it from what you're saying that you do believe that the treatments are important. Do you have any comment as to how, whether we're using them as effectively as we could be? And that certainly my experience for someone who still does occasionally clinical medicine is that the vast majority of people don't seem to know about them, and certainly accessing them has not been very easy.
Yes, I think the broader health system is learning how to do implementation. Of course, from the federal perspective, we have done our leadership work in procuring the vaccine and leveraging partners to provide guidance on how to best use the medication. But implementation is not easy because you have to get the medication into people really fast, and someone has to get a diagnosis. So, but we're seeing innovation across the country. You've heard about Quebec getting it through pharmacists being able to prescribe. Other provinces are making sure that the physicians who look after the highest risk, for example, people who have certain types of cancers and other chronic medical conditions, know how to access those medications. And I've been encouraging members of the public who are at higher risk to find out at the local level how they can access that medication ahead of time before they need it. But I think we will get better at it, and as the doses continue to arrive.
Thank you, Dr. Tam and Dr. Pawlowski. Suite M. Garon pour 2 minutes et demie.
Thank you, Mr. Chair. Dr. Pawlowski just eloquently referred to prevention. In order to have prevention, then you actually need a medical workforce, and for that to happen, you need resources, and resources have mostly been taken up by COVID patients over the last few years. Because of this lack of resources, provinces have had to withhold some types of treatments, and I'm wondering if public health believes that it is a problem, a public health problem, this lack of workforce in the provinces.
Maybe I'll start. I think Health Canada is playing a lead in terms of convening province and territory, and our ministers as well, and talking about health human resource. That is, probably one of the top priorities of the discourse and discussion of the provinces going forwards, including credentialing, getting international medical workforce trained and recognized. So all of that is extremely important. And I just want to say that it's not just the healthcare workforce, but also the public health workforce writ large. I think that is probably one of the most critical questions and challenges for the health systems in Canada.
Et si on considère effectivement, comme vous
And if, as you say, we believe this to be a serious problem, the fact that we've had to deprive a number of patients from some types of treatments because all these professionals had to be focusing on COVID. Would you not agree that if there was an increase in public health care funding for the provinces, that actually would be a way of solving this public health care problem?
But the key to addressing I'm hearing echo. The key to addressing COVID is with all the measures that we just talked about, including vaccinations and protection of healthcare workers in terms of different layers of measures. If we didn't address COVID-19, the health system would not be able to get back to addressing backlogs and surgeries, etc. So that is a very specific approach that needs to be undertaken, and so that the healthcare system can catch up on some of these backlogs. And as to the health transfers or the actual health human resource, I'm afraid that I'm not in the best position to be commenting on that. And we could be reaching back to Health Canada and the Minister for some of the plans going forwards.
Merci, Mr. Garon. Thank you.
Thank you, Mr. Garon.
Last MP to pose questions in this meeting is Mr. Davies, please, for the next 2.5 minutes.
Thank you, and I just feel obligated to state for the record, there is no coalition government in Canada. There is a confidence and supply agreement between the Democrats and Liberals. Just for anybody interested in accuracy. Dr. Tam, I'm interested in your views on infection-acquired immunity. The immunologists I've spoken to and the data that I've reviewed seems to show that there's at least some evidence that the durability and strength of infection-acquired immunity can rival, if not exceed, in some cases, immunization, or the immunization of vaccination, particularly from mRNA vaccines. I'd like to hear your views on that, and maybe ask why Canadian health policy doesn't recognize in any way the impact of infection-acquired immunity.
Well, I think we're just learning about immunity both from infections and from vaccines. I think it also depends on the variant that you're talking about. I think there's certainly evidence that variants prior to Omicron, if you had an infection, you could have quite significant immunity. That has to be monitored in terms of how long that immunity lasts for and the quality of that immune response. But when Omicron arrived, it was a game changer. And there's many things about Omicron that's a bit different. It can cause a milder illness, maybe only infect your respiratory tract before your body gets into work to fighting it. And that the immunity to Omicron variants may be quite variable. So we're still learning about that. But what is important is that we have to understand what we call hybrid immunity as well. And in some of the studies, and they're quite sparse at the moment, it shows that if you're unvaccinated and you got infected, you're more likely to get reinfected with Omicron. If you got vaccinated and you got infected, you're less likely. Your body generates more neutralizing antibodies, perhaps, but those questions remain. So I think it is not a simple question. It may be dependent on the variant as well.
Do I have time, Mr. Chair?
Very briefly, yeah, go ahead.
Last
Quickly.
Tuesday, Moderna announced that a COVID-19 booster it's designing to target the beta variant generated a better immune response against a number of virus variants, including Omicron. Does the federal government plan to procure any doses of Moderna's bivalent vaccine targeting the beta variant?
So I'm very well. I'll start, and then Stephen Bent, who's in charge of the procurement, can supplement. So I think it's very important to get the clinical trials looked at in terms of the Moderna bivalent vaccines. We're looking forward to the data. We hope over the next months on the bivalent ancestral strain plus an Omicron strain. But the proof of concept with the beta variant strain is it's promising. So, but I know that with our contractual arrangements, we have made provisions to purchase new formulations. And I don't know if Stephen has anything else to add.
No, Mr. Chair, I would just echo Dr. Tam's comment that our current agreements with Moderna allow us to access new formulations when they're approved by the regulator. Thank you.
Thank you both. That concludes
Thank
our
you.
questions to all of our witnesses here today. Thanks for your patience with the late start and the late finish. We can only imagine how busy you are, and so your indulgence is greatly appreciated, and your service to Canadians is also greatly appreciated. So thank you so much for being with us. Colleagues, just before we wrap, on Wednesday, we're going to be continuing to hear from witnesses on the COVID study, but not all parties have provided us with witnesses. So if they don't do that fairly promptly, their spots will be taken up from those who have, from the suggestion of the analysts. It will be a split meeting, an hour for witnesses and an hour to plan committee business, what we're going to be doing going forward. And yeah, I think that's it. Yeah. Oh, we're good for Wednesday. We're good for Wednesday. That applies to the meetings after Wednesday. The message is get your witnesses in, please. Is it the will of the committee to adjourn? We're adjourned.